Welcome to the Healthy Careers Podcast, where we help healthcare providers succeed on purpose. We take a conversational approach in learning from others who have been there and done that. Join us as we share expert insights from real people who are just like you, because we believe that success isn't just a destination, it's an intentional journey, and you don't have to do it alone.
All right, welcome back to the Healthy Careers Podcast. Today we have an exciting episode with a scoliosis and spine surgeon who is super innovative in his field, is more than just doing his scoliosis surgery, and we'll get to that and explain that, but I am more than happy to welcome Bassel Diebo to the podcast. Thanks so much for being here.
Thank you, Madison. Thank you for having me. This is very exciting.
Yeah, of course. So I feel I'm a little shy here because you have Brown University in your background and I have University of Rhode Island. But
All for Rhode Island.
From all paths of life, right? So clearly we can see the differences here in level of education, but I'm excited to learn from you because I think what you offer is super fascinating as somebody that has dealt with scoliosis when I was younger. But then also just the different things that you do, because you also are a director of spine research and innovation. Is that right?
Correct.
Okay. And is that through Brown University as well?
Yes.
Okay. Very cool. So let's start there. Tell us just a little bit more about how you got into the position you're in now, and then we can kind of backtrack to what inspired you to become this expert in scoliosis.
Yeah, of course. Thank you again, Madison. This is extremely exciting for me to be with you, and
Yeah.
I know about the work you've been doing in healthcare, and I'm trying to highlight a lot of exciting and important topics for everybody. Yeah, so I actually came from Syria to the U.S. about it's been about 12 years now.
Okay.
I did just a year or so of general surgery in Damascus at that time. Then there was some, the wars going on in Syria, so I kind of had to leave at that time, and I came here. It's an interesting dynamic, but I kind of stumbled into spine surgeon in Indiana, who kind of took me over and I started some form of an observation with them. Went to the operating room and I spent some time with them in the office. So I loved spine a lot, and from there I started actually doing spine research as a postdoc fellow, basically, following the MD school. And I spent about 4 or 5 years doing research in New York. I went to New York University, NYU. At that time, it was Hospital for Joint Diseases, which is only pure orthopedic hospital. It was changed then to a different name, Langone Orthopedics, I believe. And from there, I went to a Hospital for Special Surgery, HSS.
Yep.
Also did a year or so of spine research. And then throughout that time, I was trying to prepare my degree because, I went to med school back in Syria, so I had to do the exams to be qualified to prepare patients in the U.S.
Yeah, was that a pain in the butt, or was it?
A bit more than that. It was, extremely. They hold the process to a very high standard, which is extremely great. Basically, this is how I would say, protect the nation and people of the U.S. Basically, make sure that nobody just come in and just take care of them with subpar clinical knowledge.
Yeah.
It was a very, I would say, detailed process. Took years.
I was going to say, how long
and I
did
took
it
it one
take?
step at a time. Eventually, it took about 4.5 years.
Wow.
Yeah,
So
I
it
was
must
doing
mean
research at the same time.
that much more to you when it did become real, right? Because it's just like this cumbersome process, I'm sure. And like you said, it's good that they have those parameters in place, but for the right people that are here for all the right reasons, I would assume that at some points you feel a little frustrated by it as well, just the timing.
No, absolutely. I mean, this is, I always say this is one of the best lands on earth, and it's the best country, and a lot of young, talented individuals seek, kind of a resort here, or they seek better lives. At the same time, the institutions here and the governments are always up there trying to ensure some level of knowledge and clinical
Yeah.
satisfaction that the patients would receive when they encounter those folks trained outside the U.S. Or educated at least outside the U.S. So yeah, it took long, but it is definitely very satisfying in the end.
Yeah.
And you feel elevated into a certain level of knowledge beyond what you had.
Yeah.
So at some point you feel you have, the old world, knowledge and values and everything, and then you combine it with the most advanced clinical knowledge here. So it's kind of a nice combination that people actually feel when they talk to you, because you have a kind of
Diverse, yeah,
yeah,
outlook on it
something,
all.
yeah.
Yeah.
So yeah, and then at that time I applied to be trained as an orthopedic surgeon, basically for
Hmm.
residency.
Okay.
And then I matched at the State University of New York in Brooklyn, SUNY
Hmm.
Downstate. I spent about 5 years there as an trainee, an orthopedic surgeon in training. Then I graduated. So that was about 2.5 or 3 years ago now.
Okay.
Um,
And
and
now
then
you're
from
finally
there,
able
we do
to.
something called fellowship.
Yep.
Basically, it's a 1 year of subspecialty, and I know I loved spine surgery a lot, so I wanted to be a spine surgeon.
Hmm.
And among all the fellowship options that I had, which I think there were about 15 or 16 interviews I got between
Yeah.
multiple institutions in the country, I decided to come to Brown.
Yeah. Brown's a great place. I'm biased towards it because I grew up in Rhode Island. So I think the campus is beautiful nonetheless and super convenient to that little downtown area there. I miss it, but
Yeah, it's a
um,
gorgeous place. It's a very, I would say, unassuming yet highly functional and efficient city.
yeah.
Providence is really nice. The amount of, or the number of highly educated folks and dreamers there, it's very high.
Yeah.
Um, they often get tagged as a small city or small state, and I would say benignly or unintentionally, people don't take it as seriously as New York or a big place.
Right. Or
Uh,
Boston. Yes.
exactly. But yeah, I mean, we're trying to do big stuff from Providence these days, and
Yeah.
I believe we're providing excellent clinical care and even education for the trainees.
Yeah. I think so too. And I think New England in general, I've actually lived out of the country. So I lived in Panama,
Oh,
and we also hosted somebody that was from Argentina who stayed with us as well, like an exchange type of thing. And then I've had friends that trained actually their medical school, they went out of the country. And so it's
wow.
interesting to see and hear the different perspectives. And then also from a schooling standpoint, I don't know if this was the case for you coming from a different country, but Brown, Harvard, all of those schools are, they hear them in the movies and they hear them and it's well known. But I feel like Rhode Island or Providence doesn't get a lot of street cred as some of the other prestigious schools do, like you're saying, just because of its smaller nature. But just super smart people and a lot of medical advancement, which we'll get to as well in terms of your thoughts of where the industry and where things are going and where you hope to see it go, because I know you do a lot of that kind of stuff in your research position.
Yeah, yeah, absolutely. Yeah, I think, yeah, I'm not sure. I mean, I think I always say that the airport has something to do with it because it's a small airport.
Yeah.
And it always, and it's funny when in leadership meetings with University Orthopedics, which is our
Yeah.
private practice that is affiliated with Brown and with the healthcare
Hmm.
system, which is Lifespan. I always throw in the idea, and it's a semi joke that we should lead a campaign to rebuild the airport and make it at a terminal, international terminal, because the more we
Yeah.
grow, I mean, we do have a lot of visitors right now to come see us operate and come, see what we do, and they come from different part of the world.
Hmm.
We just had a French visitor, another French visitor before that, another French visitor before that,
Wow.
three spine surgeons. I have
Is
also.
there a reason why it's all coming from France? Like, is there a relationship there or is that just ironic?
So what we do is, in terms of reconstruction of the spine, or we call it realignment.
Yeah.
What we do was kind of born in France as a concept. Uh,
Hmm.
the father of modern spine surgery, his name was and is still John de Busset. He's almost in the, I think, mid 80s now.
Oh,
He
wow.
came up with a lot of concepts that eventually was built upon to generate ideas and techniques and tools to realign patients that have severe scoliosis or severe kind of postural issues that cannot stand up straight. As much as we know today was kind of generated in France at some point. So a lot
Okay.
of the passion is carried throughout generations in France,
The
and
influence, yeah.
eventually the U.S. kind of also adopted a lot of the concepts and built on them and advanced them.
Mm-hmm.
So now between us and the Europeans, they're always like back and forth, between exchanging knowledge and see what we
Mm-hmm.
do here, what they do there.
Yeah.
So I do have a lot of connections in France, and those are basically the mentees or even the one of the pioneer spine surgeons in France that come here and just change ideas with us, and we do the same. I'm going on a traveling fellowship very soon, actually.
Oh, cool. Where are you going to go?
So I am the ISSG traveling fellow for this year. It's
Mm-hmm.
actually the inaugural year this year. ISSG is the International Spine Study Group, which is basically a study group that is a collaborative effort between I would call them the top institutions in the country in terms of volume and their ability to care for complex spine reconstructions.
Okay.
So we combine efforts to build a body of research, basically a database that look into ideas and concepts and new techniques, kind of publish them to the community to kind of advance the field. So this year, the ICG granted me this traveling fellowship where I chose 5 centers in the country to go and see the techniques they're using and exchange some
Yeah.
ideas with them, learn from them, and
Very
so
cool.
I'm doing that. Yeah.
So, are you able to share where those locations are, or is that like not yet?
No, no, of course.
Okay.
For the ultimate,
I
no, no,
never know what's confidential or what's not.
no, no, of course. Yeah, I mean, I would say the first visit would be in Johns Hopkins. It would be next week.
Oh,
Um,
awesome.
yeah, I'm
Yeah.
visiting Dr. Kabesh, Kal Kabesh. He's,
Hmm.
to me, I would say one of the best surgeons in the world today, taking care of this adult scoliosis. And then afterward, I go to Columbia Presbyterian to visit Dr. Linky, Larry Linky there. He's also one of the world experts in scoliosis. I then visit New York for a couple stops. One of them is Hanjo Kim and Hospital for Special Surgery, and then my mentor Frank Schwab at Lenox Hill, Northwell Health.
Okay.
Then from there, I go to Colorado to visit Shea Bess. He's the president of the ISSG and a great
Very
surgeon
cool.
and a leader. And then I go to San Diego to visit Peter Newton and Mike Kelly, also members of the ISSG and the Harm Study Group, also
Awesome.
scoliosis experts.
Yeah. Well, I love San Diego, so I'm jealous that you're going there.
Actually, IMAS is there now. The IMAS SRS meeting.
Yeah.
It's actively going right now in San Diego.
Yeah, it's a beautiful spot. I actually, and this will lead to a question for you, and I'm super curious because you came from a different country. When I was looking at schools, originally I thought I wanted to go into medicine and I didn't know what I wanted to do, but it was always an interest of mine. I studied health sciences and then I figured I'll figure it out and I'll go to graduate school, whatever that might be. And when I first started college, I thought, well, I'll be a speech language pathologist because I like to talk, I'm personable, it'll still give me that, medical professional, but I can't really do blood. I wouldn't be good in surgery. I'm not detail oriented, so you don't want me doing anything that requires extreme, like, what you do, for example. And I picked Towson University in Maryland because they had an affiliation with John Hopkins. So I remember like my freshman year when we were in the speech program, they basically a lot of the stuff that you were doing to get into that program to apply for everything was through basically a satellite office that was affiliated with John Hopkins. And I thought, well, if I go there and then I end up going to graduate school, that would be a great place to start because everybody knows of John Hopkins. But I ended up actually recruiting in college, and then I never went to graduate school. My advisor was like, you've got really good grades, like you could go apply. And I thought, nah, I don't want to spend more money. But I mean, for you, did you always know I want to be a surgeon or I want to be a physician? Did you always have that inkling, or was it something that influenced you along the way as a child?
Um, it's funny because as far as I can remember, I wanted to be a surgeon. I don't remember not wanting to do that. Maybe 5 years old or something. It
Wow.
was like silly, but I do love it. And my dad, who actually passed away last month,
Oh, I'm so
he always used
sorry.
to say, he always used to say that, I got you this little store, right in that neighborhood. That's going to be your, your office, your clinic. You see patients there, and I was like, all right, Dad. I mean, I was like 11.
Yeah.
But even before that, I always wanted to be a surgeon. I like the gratification of helping others in a rather short period of time, because
Yeah.
it's counter to my nature to uh, try and work on something that needs about 20 years to get to feel successful.
Mm-hmm.
So I like immediate execution of a specific plan that takes somebody from A to B, and B is much better than A.
Yeah.
So to me, it just fits my brain dynamic, I would say.
Mm-hmm.
So yeah, I loved it from the beginning. The spine came when I got here, because it's funny, in Syria, orthopedic surgeons don't do spine. Only neurosurgeons do spine.
I was gonna say, yeah, so yeah.
Yeah, so I didn't think of it at that time. I liked orthopedic surgery. I just didn't start it as residency in Syria.
Yeah.
And when I got here, all I wanted to do is be a spine surgeon. And I used to tell people, which kind of sometimes offended the orthopedic surgeons. I was like, I would do anything in the world. You can throw me in neurosurgery residency, you can throw me in neurology residency. I don't care. I just want to be a spine surgeon. Whatever you want to teach me otherwise, you can, because as you know, there is no spine residency specifically.
Right,
There's no
right,
spine program. It's a fellowship. It's a
right.
subspecialization. And we're actually advocating for a bit more extensive spine training for our trainees, because it's only part of orthopedic surgery at the moment.
Right, yeah.
Um, Actually, it's about 6 months to maximum of 1 year in the best case scenario.
Mm-hmm.
But then when they go to fellowship, they have extensive training for a full year, dense with 500 to 600 cases. Our fellows here hit about 650 cases a year in their
Wow.
fellowship, so they do see a lot. They do train
Yeah.
extensively. Uh, but yeah, I wanted to be a spine surgeon here, and I just thought I fit well with the orthopedic surgery kind of club. Kind of low key.
You
There's
mean the frat bros?
well, it used to be.
I'm just kidding.
We're, we're trying, and we're trying to be at least the bodies, scientific bodies of orthopedics, and even the governing bodies of the academy, and Scoliosis Research Society, American Spine
Yeah.
Society. Extensive efforts for years right now, at least since I started in this field about 11 years ago, 10 years ago. At least from our lab, I remember
Mm-hmm.
there was, Mimi, Jensen, and I would say Nina. There was multiple. At that time started the movement of, like, why are we not too open to others?
Yeah.
And some, I would say some people were actually intimidated by orthopedic surgery, so they wouldn't even apply for it. They was like not even
Right.
considering applying for it. So it was a combination of multiple factors. When they felt that there's some understanding and some open-minded folks in orthopedics, everybody started applying from all walks of life.
Yeah.
And now we're, I would say, not where we want to be, but I think we're infinitely better than 2 decades ago.
Oh yeah.
Even a
Yeah.
decade ago.
Yeah. And I would imagine too, this is just kind of down a rabbit hole, but it was on my mind. I'm big into fitness and just wellness and all of that, and I'm a huge advocate for it just because of my own personal journey with it. But I think a lot of times we think of scoliosis, at least in my mind, as something that happens when you're a child, right? Like somebody is born with it and there's some deformity, right? Or somebody gets it as a child. But a lot of times we don't think about it as an adult. But I would imagine with how technology driven our world has become with people, and everything is heads down, right? Everything is, I sit there and I'm even at my computer. I mean, I get to this position where I'm bending over and I'm not in the correct position to support my spine. And I would assume that as time goes on, the demand for what you do is going to grow exponentially because they didn't have that problem. I mean, they did, but I feel like it's not going to be as big as now you see all these people. Most jobs are behind a computer screen or lunging, like not in a good position for the spine.
Yeah, so the scoliosis does have multiple types. The most common is the ones we know as teenagers. The general public
Mm-hmm.
know as a teenager scoliosis that get picked up by the nurses in the schools or some primary
Right.
care physician on kind of a routine clinical exam. But what's even more common, believe it or not, is adult scoliosis. I would say there are multiple studies in the past. One of them by actually Frank Schwab, my mentor, showed about 60% of people after the age of 65 have some form of scoliosis.
Hmm.
But to be very clear, this scoliosis form is different than the teenager form.
What
Uh,
is the difference?
the difference is the teenager form, you technically are born genetically with it, and then
Mm-hmm.
it will show around the teens year. Uh,
Okay.
but the adult form kind of generates secondary to, I would say, arthritis or
Okay.
degeneration of the discs and ligaments and even the bony erosions. That will make the spine eventually change the shape of it into a scoliosis shape. But it's totally different than scoliosis as teenagers. So adults do have a lot of scoliosis in multiple severities, mild, moderate,
Mm-hmm.
severe. And environmentally, I would say genetics has a lot to do with the arthritis component of it, we
Okay.
call it degeneration,
Sure.
and there's a lot of vocabs in spine that I feel sometimes they are offending to patients. Whether it's a deformity or degeneration, and I feel bad saying them, and we're actually advocating for change of terminology that we've just started this wave,
Oh,
calling
okay.
things differently.
So
Uh,
what would it be changed to? Because I just said deformity, so I guess I'm not woke to it, right?
No. I would say deformity is we're trying to change it something around malalignment, uh,
Okay.
which is
That
kind of
works.
it's kind of a global broad term that could
Mm-hmm.
cover what we mean. It's still a little bit vague, not very specific, but it kind of relay the message. In terms of environmentally, again, so its genetic component has a lot to do with arthritis.
Mm-hmm.
You can ask anybody with some form of arthritis in their knees or hips, did your dad or mom have arthritis? So, oh yeah, absolutely, my mom,
Yeah. Yeah.
total hips and total knees and all that. But if you add the genetic predisposition to a, let's say, a poor lifestyle, to prolonged sitting position, to poor posture, all those could lead to some form of malalignment or scoliosis,
Mm-hmm.
or exacerbation of it. Um, and I always try to advocate and talk to my patients about posture. But to be honest with you, a lot of people could live their life um, in a way that's some others could say it's suboptimal,
Yeah.
but they won't get any of those diseases. So it's hard to kind of be
Pinpoint.
black and white about it.
Yeah.
It's fun. It's funny. I was in Westerly over the weekend for the ISSG spring meeting. We were at
Okay.
the Ocean House. It's a really nice
Yeah.
resort.
Watch Hill.
Yeah, and there
Mm-hmm.
was a piano player down in the around the bar,
Okay.
and this guy. I walked in around noon. He was playing the piano, but I couldn't see his face when I came toward the piano. So he was totally down like that.
Yep.
His neck is totally 90 degrees to his torso, like this.
Mm-hmm.
I don't know, maybe he's comfortable or something. I left. I had a meeting for 3 hours. I went back. He's in the same position, and I was like, obviously, I'm a
I have
spine
to say
surgeon, so I
something.
had to say something, right? So I was like, hey,
Take
but
my
he was.
business card.
I would say this is in his 60s. He was in his 60s. I was like, I just, you've done great. This is fantastic performance.
Mm-hmm.
But maybe if I were you, I would try to kind of change my posture as I do
Posture.
that. He goes, son, they've been telling me this for 30 years, but I have no problems. I was like, you know what? You live, you win. I'm going.
Yeah.
I just want to tell you that.
But I also think that, and this is, I feel like, true for a lot of things, is that, like, if you look at my grandparents' generation, they underdiagnosed. And then I feel like our generation overdiagnoses to where like, I think the stereotype of like, oh, when you get old, you just naturally start to bend over. And it's like, no, I don't think that's true. Like, I think that we allow ourselves through bad posture, through not strengthening our back and our, hips and making sure that we're focused on mobility and flexibility and lengthening our muscles and just staying fit and eating healthy that yeah, of course. If you are sitting in a chair all day watching Jeopardy, or you're not stretching and raising your hands up and doing things that would promote spine health, yeah, you're going to end up bent over, right? And you're going to have that hunchback as you age. And you see it so often. And it's just now like, you ask a kid, act like an old person, the first thing that they're going to do is hunch their back. And I think that we underdiagnose that. And probably many of those people, like you said, even if they're not having problems, have some form of scoliosis.
Yeah, correct. I mean, also the problem with spine conditions, that life is unfair to them. Meaning, if you walk a mile a day, you have trained your quads, you have trained with your legs and everything. But our lifestyle is very unfair to the spine because the spinal muscles are not necessarily involved with your daily life as much. So,
Yeah.
and what I mean by that is, have you done yoga before?
Oh, yeah.
So
I
when
love
you
yoga. I need
when
to do
you
it more, but
yeah, so when you did yoga for the first time, there's always this feeling that you have just moved a muscle you didn't know you had.
mm-hmm.
So, as of you're part of daily life, the spine doesn't go into extreme range of motions to train that muscle. It has
Yeah.
to be a special, workout. Is it Pilates or swimming or yoga? So, daily usual gym stuff, they don't normally touch the spine as much. I mean, they do, but not every single muscle of the spine. So
Right.
that's why I feel spine conditions need, special supervised physical therapy that leads to specific movements of specific muscles.
Mm-hmm.
So that's why it's tricky to keep spine health, really optimal.
In check. Yeah. Well, and even as a gym goer, I look at some people in their form, and I'm not perfect by any means. And there are times when I'm deadlifting and I'm like, why does my lower back hurt so much? And it's because my form, because if I was doing it correctly, it wouldn't hurt that much. But I think so many people focus on the weight. And one thing that I've had to incorporate into my training as I'm getting older, and I'm not old, but just as I'm getting older and being more aware, because when you're 21, it's like you can bounce back and nothing hurts you. And then you start to approach 30 and you're like, wow, I didn't think that I did that much weight, but everything hurts. And I've started to do Pilates, and it's hard as crap. Like, it is so difficult because it is pinpointing those muscles that you're just like, what even is that?
Yeah, yeah, you don't know exist. It's awesome though, and that's again, if I were to tell somebody anything about their spinal health, I think those exercises, obviously in those that have
Yeah.
no spine issues that could get worse because of them, um,
Mm-hmm.
under supervised, clinical provider, I would say, Pilates, yoga, swimming, side strokes, are some things that are really could be life
Good.
changing for a lot of people,
Yeah.
with kind of a minimal or at the beginning of their spine issues and conditions. Always keep your paraspinal strong,
Yep.
because the deterioration of the muscles in the back is actually part of the disease process.
Oh.
It's not only the discs that go away. It's not only the bone that has arthritis in it. It's also the muscles that become something called, it's like a bougie scientific terminology called sarcopenia. Basically, the muscles get exchanged with fat, and you
Hmm.
don't have to be overweight to have fat in the muscles.
Right.
It's
Yeah.
not, you know.
Yeah.
So that was, oh, what do you? No, it's fatty infiltration of what's supposed to be muscle fibers, and
Hmm.
that's when your bones start kind of gradually move forward in scoliotic shape,
Okay.
or malalignment, because your muscles are not holding the skeleton as much as before.
Interesting. Okay. And so do you think, and this is just my own take on it and more my curiosity than anything else, when you talk about upcoming innovation, and this is something that I know that you're also passionate about, or you think about where scoliosis is leading to, I think historically in healthcare, everything has been reactive. Everything is now I've got this problem, so I've got to rely on this medication, or I've got to rely on this surgery, or I've got to do this PT to now go back to what it was before, try to at least. And I've seen a huge shift in the mindset of people in this upcoming generation of being more proactive so that we don't have these issues, and less reliant on medication, less reliant on surgical intervention. So from your standpoint, like, how do you foresee that playing itself out, or what are some of the upcoming things that you anticipate within the scoliosis realm?
Yeah, that's a great question. I think in the past few decades we got better from surgical standpoint into being able to use instrumentations to reshape the spine the way we want it.
Mm-hmm.
Back in the day, it was really hard for us to do that because the spine is often not a flexible thing. So if you are a surgeon and you are operating on a patient, when you look at their back, after you do the exposure and everything, you're about to do the correction. It's not necessarily this little like dominoes of boxes that you can like move, and put together.
Yeah.
It's actually fixed with arthritis or some sort of, it's a stiff curve. Um, until Cottrell Dubuisset, at least 30, 40 years ago, two spine surgeons are friends.
Mm-hmm.
They came out with segmental fixation of the spine, where it allows us to move every unit the way we want it to put it back straight.
Mm.
So we got better at those. We are able to move the spine. Period.
Yeah.
What we are about to what we started noticing that we can fix it, but the longevity of the treatment is really short. It's like,
Mm.
2 years or three, there is some form of, either minor complication that would happen, or return to the operating room to tweak some little construct here and there, or the rods that we use, like break, for example. So there's multiple issues regarding the longevity of the treatment.
Is
Um,
that mainly because there could be a genetic thing going on with that fat in the muscle, or is that largely just because of the surgery in itself as to what you're able to implement?
I think a major part of it was the scientific and the surgical community learning curve,
Okay.
because it's new science.
Mm-hmm.
Example, if you think about diabetes,
Yeah.
the treatment for diabetes today wasn't born 3 days ago, or
Mm-mm.
or even 10 years or 20 years ago. The
Yeah.
treatment of diabetes came a long way, all the way to what? To Ozempic.
I was
That
just about to
actually,
say, and now they can't get their Ozempic because
right.
everyone's using
So
it for non-diabetic purposes.
Right. So it came a long way to a point where, boy, somebody takes Ozempic. Some of my patients I don't recognize when they walk in. It's like 30 pounds, 6 weeks, meaning
30 pounds in 6 weeks?
yep, yep, flipped his lifestyle and everything. So it's kind of like a little push that people sometimes need. I mean, we always
Right.
try to fault somebody for their lifestyle, or they don't go to the gym, but sometimes you get to a vicious cycle where you just cannot come out of it.
Yeah.
For a lot of reasons. Could be mental, could be whatever it is. But guess what? This is what you are dealing with. Someone that is in a vicious cycle. You know,
Yeah.
I don't care about the why, to be honest. I care about breaking down the problem and addressing it one by one.
Yeah.
Um,
And I'm sure the extra weight on people when they do have issues in their back is just, if there's less weight that they have to carry, it makes it a lot easier for
mhm.
that intervention, for
Absolutely.
that,
A lot
yeah.
of back pain get better with losing weight. Actually, this exact patient I just thought of, his back pain got better from he used to say 12 out of 10 to like 8 out of 10.
Wow.
So
Yeah.
he's on the way to recovery. He actually came in. He wanted surgery. I told him, listen, we have 3, 4 other things to start optimizing before we go into any other
Mm-hmm.
discussion about surgery. One of them was weight loss, and he was very nice and understanding about it. I was like, you know what, he felt he wanted to do it, and he did it.
Yeah.
So what we are heading to is better execution of surgical treatments.
Okay.
We're looking to try to make this construct have longevity of 10 years or more, 15 years. Our gold standard is always hip replacement in orthopedic surgery, because
Mm.
hip replacement today, by all numbers and research, is one of the best surgeries humankind ever came up with. It's just 95% success rate, even more in some institutions. barely, you get it done. You could go home same day in some institutions, and then
Right.
you feel so good for like years and years. You rarely get revisions or anything. So we are trying to get closer in spine. We're trying to get closer to the longevity of total hip replacement, or hip replacement in general, and that's what we're heading to. Better execution, robotic assisted execution,
Mm-hmm.
navigation assisted execution, uh, intraoperative, meaning inside surgery. We're trying to have more technology that allows feedback that we have actually executed the plan we intended to do,
Yeah.
which was always a disconnect because surgeon was
Yep.
like, as you look at the body, especially in a position where the patient is laying down,
Mm-hmm.
you are not 100% sure how they're going to stand up. That was the feeling like 15 years ago, for example. It's like, all right,
Wow.
I corrected the scoliosis, I gave the patient certain contour through the rods, but I'm not sure if she's going to like it when she stand up. Maybe not, maybe yes. So now we are more sure what patients like versus not through data.
Yep.
We're more sure that we're executing the plan through robotic assisted surgical planning, through multiple platforms and softwares.
I have a question
Um,
about robotic surgery really quick, and
sure.
this might seem super juvenile of me, but not being a healthcare professional or a surgeon, how does that work? Like, so you plan the surgery and this robot, like, doesn't that take the job away from you? Or are you're obviously in the OR with this robot, correct?
Correct.
Okay.
Yeah. Yeah.
As if I was having surgery and they're like, meet Fred, I'm like, no
Right.
thanks.
So wait, Basil, did you leave? It's like, no, I'm here. I'm still here. Drink coffee. No, it's not like that. So robotic spine is also different than robotic general surgery.
Sure,
For
sure.
example, there's a robotic company in general surgery that's been in the market for decades, and now they are on, like, they call it Da Vinci. Actually, they're on Da Vinci like 7.0 or something. They have reinvented the robot about 6 or 7 times. Um, Spine has just
Wild.
came up with their robots like a few years ago, basically.
Right,
So
right,
we are
yeah.
1.0. 1.0 meaning a ton of surgeon involvement. The robot does help today with placing instrumentation, but the robot does not make the incision, does not approach the spine, does not do the dissection, does not perform bony cuts or carpentry that we need to do, does not relieve the pressure of the nerves if we need to do something called decompression or laminectomy. Um, but it places some of the instrumentation safely, basically.
Okay. And does that eliminate the need? And again, I apologize if this is coming across as silly questions, but for me, it's just curiosity. And I'm sure a lot of other people that listen and who aren't in this specialty might also be wondering the same thing. I hire a lot of physicians, but I also hire a lot of APPs. So when you look at like a surgical PA, would this robot essentially be replacing some of the duties or some of the things that they would be assisting with in that surgery?
I would say not in the current form, uh,
Okay.
but I know, I'm close to a lot of engineering teams,
Mm-hmm.
for industries and corporate partners where they're inventing and try to, a robot 2.0, 3.0.
Okay.
The goal is eventually for the robot to eventually take more parts of the procedure, and the ultimate goal is to make the procedure reproducible. Basically, it is performed methodically the same way every time.
Mm-hmm.
We try to do that as humans all the time. But for example, today the plane is not made by engineers. Largely, it's made by robot that execute the engineering plan that
Oh,
put
don't
the
tell me
engine.
that.
You
I'm
know,
petrified of airplanes.
yeah,
That's my fear.
yeah, especially the last one.
Yeah, exactly. Oh my gosh. And I swear, I feel like my phone hears me talk about it. And then I open my Instagram and it's like, door swings off airplane, like plane forced to land. And I'm never flying again. Just catch me in my car. I'll be in my Forerunner driving 18 hours to Rhode Island.
Yeah, it's there's always an error that happens, either by
Yeah.
machinery or by humans. Unfortunately, we're not perfect by any means.
No, I
So
mean,
the
humans
robot
have
will
fault
take more
too.
stops, more. I would say robots will take more parts
Mm.
of the surgery, but we're really not there at all. I mean, I think it's going to take decades.
Yeah.
Eventually, the robot will enable, I would say, again, more reproducible surgery, perhaps on a larger number of patients more efficiently at the same time, perhaps.
Yep.
And then again, it's a hard topic to talk about, but the liability is a big question. There's
Yeah.
somebody that has been, it took me what 20 years to be a spine surgeon. Um, I can be liable on actions I do in front of bodies of or institutions,
Yeah.
but you know, you know,
How do you persecute and
right?
robot?
How are you gonna sue it? Basically,
Yeah, yeah.
somebody human. Uh, until we get into super intelligence AI,
Mm.
we're only AI. We're only artificial intelligence. So it's really artificial. Meaning, I think we are ways ahead to get to super intelligence robots that are highly more intelligent than humans.
Mm.
Because I believe humans remain smarter than robots today. Any robot,
Yeah.
because they can adapt.
Yeah.
And in medicine, adaptation is very important
Yes. But I
because
also I think too the thing that is interesting to think about, because as a patient or a consumer of healthcare, I think there's also going to be a lot of pushback on people that are say, okay, yes, that robot can perform my surgery. But I also think then if people understand, or if someone said, well, utilizing that robot is reducing the risk by X amount for X, Y, and Z to happen. And I know that there's not necessarily tons of data around that now, as you said, because it's not super intelligence and it's the 1.0 version. But I just think I'm a huge data nerd. So when I think about that, I'm like, I wouldn't be comfortable with it unless somebody were to tell me you're actually safer doing it this way than the other way.
yeah, because you know I hate to say that medicine is an art because it has an art to it,
Hmm.
and the art is narrow. The margin of art or the amount of art in medicine is shrinking by the day. But the last frontier of that will be the relationship between the patient and the surgeon.
Yeah.
And that relationship sometimes it stays for years sometimes. And
Hmm.
before the patient consent or agrees or mutually agrees with the surgeon to have a surgical intervention, there's months and months of preparations, especially in scoliosis cases, the ones that I like and I do. There's a lot of optimization that happen and that build this little. It's like a journey. There's a bonding
Hmm.
experience between the patient and the surgeon where say, all right, we're going to take care of your nutrition, we're going to take care of your bone health, we're going to go, get treated for osteoporosis, we're going to make sure that your labs are normal, we're going to make sure that even you're mentally prepared. I mean, some of my patients, and it's part
Yeah.
of my workup, they go for neuropsychology assessment, and
Hmm.
anything anybody can do to make them feel better, stronger before they have the surgery, I'll do it for them.
Right.
So
Because then the outcome is going to be that much better because you're tackling everything proactively that, I know for me, I would be a nervous wreck, right? So understanding, like, I'm the type that goes to the doctor and asks 400 questions. And it's like, but I want to know. And otherwise, I'm going to have questions and I'm going to be anxious about it. Whereas if you almost like, I like to use the phrase of calling out the elephant in the room of like, you know what everybody's nervous about. So let's just talk about it. Let's get it out there on the table, clear the concerns so that when it comes to the actual thing, you're prepared. You know exactly what's going to happen. And then the patient outcomes or the outcomes in general and your relationship is that much stronger.
Absolutely. I mean, the patients, as long as the patients, in my opinion, as long as the patient knows exactly where you're heading to, what's the
Mm-hmm.
expectation out of it, uh, being surprised with something is the most frustrating for anybody,
Mm-hmm.
especially if you're undergoing this kind of procedure. So
Yeah.
I do think that robots, if we go back to our point, I think robots will take a lot of the execution away from the surgeons, or actually in collaboration with the surgeons, which I'm totally fine with. I think it's a great thing. And I actually use a robot on my scoliosis patients sometimes if I
Yeah.
feel it's necessary. Um, it will take that execution part, but eventually it will never take the relationship between the surgeon and the patient. That
Yeah.
always has to be there, and it cannot be robotically managed. I believe, at least
Yeah.
not in any
Recent time.
anytime soon.
Yeah. And I think too, what needs to also happen is I think a lot of places from a business standpoint look at robotic surgery and they're thinking, ooh, okay, if they can help, that means we can get the surgery done quicker, which means we can fit in more surgeries, which means we can bill more, which means that we're going to profit more. And I think if you're looking at it from that standpoint, it's like you're pushing for it in the wrong way. Yes, it will achieve all those things as a byproduct of you focusing on how you can, like you said, make the actual procedure better, make the resources and the outcomes and the success rate and the longevity of the procedure longer. Well, then great, right? And that the profit and the ability to do more with less is a byproduct of that. But I think a lot of people see it from the other scope, the other end. and,
Yeah.
and that's where it's like you need to be careful, because that's where that relationship, that trust is. Patients don't want it because it makes you richer. Patients want it because it makes the outcomes of their surgery more successful.
Absolutely. I think, as long as surgeons or say, spine care providers are close to innovation, as innovation that is run by corporates or industry, as long as they're close, we will always ensure that the solutions coming out of this innovation is reasonable to the patient.
Yeah.
What the problem happened, and it happened in the past, and companies will take a certain strategy where they create a product that could be, we call it over-engineered, or like really they didn't think about certain tweaks that we deal with every day with the patient. That's when it becomes an over-engineered equipment that is not really clinically relevant or applicable. But as surgeons, especially us, some of us that are involved in academia and research and innovation in general, not necessarily academia. There's a lot of private practitioners that are actually innovators.
Right.
We are close to those things, and we always weigh in a way is like, well, how are you going to use this to make the treatment better, rather than I don't care
Anything
about your
else.
relationship with this
Yeah.
hospital, the hospital, or your sales or whatever.
Yeah.
How's
Or
that?
the headline of like, this hospital's now using this, innovative technology. Yeah. Yeah. I think it's all stuff that it will be interesting to see over the next years and decades what's to come. But it sounds like you're in an awesome place, and I look forward to just kind of seeing how your career with your expertise progresses, and hopefully having you back on the podcast when some of these innovations actually come to fruition, or after your travel fellowship to learn a little bit more about what else you've learned.
Perfect. I would love that. Thank you, Madison. I really enjoyed my time here. And anytime you want me back, I'll be there for you.
Perfect. Thank you. Sounds good. Till next time, everyone.
Good day.
Thanks for listening to the Healthy Careers Podcast, where we provide a platform for you to ask hard questions and get real answers. If you enjoyed this episode, don't forget to subscribe and share it with your friends. Stay tuned for more episodes every other Friday at 7 a.m. Eastern.